So APIN Public Health Initiatives was created in Nigeria in year 2000, and it came as a project of Harvard School of Public Health in year 2000, saddled with prevention activities, basically in tertiary institutions or teaching hospitals in Nigeria. So in year 2004, APIN became, the name APIN Plus came about, and that was when the activities around PEPFAR, was coming on board and so on. So in year 2008, APIN became an indigenous organization in Nigeria, right? And since then, several projects had been implemented. Okay, so in 2008, APIN implemented a comprehensive HIV/AIDS prevention, treatment, care, and also supported 10 states, under the President's Emergency Plan for AIDS Relief, which is PEPFAR. That was a 5-year cycle project. And in 2012, APIN also implemented the Comprehensive AIDS Response Enhanced for Sustainability. We call that CARES project. That was another 5-year cycle that ended in 2017. Concurrently, in 2012 and 2017, APIN implemented a laboratory project called Capacitating Laboratories for Accreditation, Strengthening and Sustainability class. And this is one of our APIN strengths, is a laboratory infrastructure development, preparing laboratory for accreditation globally. So essentially that was what class was about, implemented between 2012 and 2017. Global Fund grant by APIN was implemented between 2012 and 2016. Essentially between 2012 and 2017, about 3 programs were running concurrently with APIN in Nigeria. So from 2017 to 2022, APIN implemented the ICARES project, and that is improving comprehensive AIDS response enhanced for sustainability. Within that period as well, APIN implemented the World Bank Save 1 Million Lives program, which took place in 5 Southeast states and Benue State, and that was in 2018. And then along that, we also had a Nigeria State Health Program Investment Project. We call that HENSHIP, which took place in Taraba, Gombe, and Bauchi State. Overall, APIN had its footprint in 26 states in Nigeria since inception under various projects. In Nigeria, when funders come into the country, they do their own site assessment, state assessment, and look at where different states need support. And beyond that, there are several implementing partners working in the country. So there's a plan to ensure that program get to necessary states. So they define where each IP implementing partner goes, and in the spirit of equity, having access to health and so on. So most times it's beyond APIN to choose where she wants to work. So it's tailored and then balanced out by the funder to ensure that we have a right spread of interventions going on in every state in Nigeria. All right, so when that mandate came from UNAIDS, it became something that all the states, all the implementing partners in HIV/AIDS field needed to run with. And APIN wasn't left behind. The way APIN structure is built is really heavy on partnership and collaboration. And that sounds like the bedrock of every successful program. So APIN is able to engage with different health facilities in which the care providers, the caregivers, help to drive HIV/AIDS response within the country. So when this mandate was released, there was appropriate engagement with necessary stakeholders, and APIN was able to push the agenda, bringing everybody to the round table ensuring that there is a buy-in, there is understanding of what 95, 95, 95 is all about. That also wasn't a one-off engagement. It was a continuous, skill building, capacity building, letting people understand where we are in terms of achieving the UNAIDS goal. At some point, states were categorized into different level of achievement of this goal, and then we have states divided into red, green, and yellow based on the level of saturation, based on the achievement of the 95-95 goal. So this particular coloration of each state based on the achievement of the goal helped APIN to drive various activities, various interventions that are tailored to ensure that the states that needed more response, get additional attention and also resources. I just talked about the color. I didn't really explain what that means. So for red states, red states is, let me say, is the worst place that a state could be. What do I mean by that? It shows that there are a lot of gaps in terms of people that need to know their status. Remember, the first 95 is about having or ensuring 95% of people that know their status, that people that are living with HIV know their status. So red states shows that there is a wide gap between the knowledge of HIV status and people that are actually infected now. So for the yellow states, the wide is a little bit narrowed. In other words, those states were moving towards epidemic control. I mean, epidemic control means ensuring that people that are actually infected, 95% of them are able to know their status. And then the green state is what we called, we have achieved epidemic control. In other words, those people that need to know their status, 95% of them had that understanding. And of course, 95% of them also had been placed on treatment, and then 95% of them have also achieved viral load suppression. So in such state, what we need to do is just to continue with mop-up activities and ensure that prevention activities are heightened so that the remaining people who are still infected will not be able to, drive the infection anymore. So activities were tailored, as I said, and part of the thing that we did as APIN is to bring in different strategic and innovative interventions to ensure that that first 95, which is very critical, is a bedrock of the second and third, is achieved. And, part of how the result or outcome of our intervention really showed, because out of the 5 states that we work currently, 4 of those states have achieved the first milestone of epidemic control. In addition to already highlighted projects that APIN implemented, we are running a new one funded by CDC. Is a continuation of a PEPFAR intervention in Nigeria, named Accelerated Comprehensive AIDS Response and Epidemic Control and Sustainability, called Alpha Cares Project. And the purpose of this is also to continue in HIV care treatment for people living with HIV. APIN is currently working in about 405 facilities across 5 states. In Benue, we work in 264 facilities. In Oyo State, we have 41. In Plateau State, 35. In Ogun State, 33. And in Ondo State, we are in 35 facilities. So these facilities are directly in touch with the PLHIV in terms of treatment. And across all these 5 states, APIN currently provide treatment to 375,552 patients living with HIV. And this automatically places APIN as the implementing partner with the highest number of PLHIV, taking care of highest number of PLHIV in the country. Excellent. So UNAIDS is currently using the Traditional Wellness Day for 2023 to highlight the importance of the community. It's currently urging every government or the world to use the power of grassroots, because when the grassroots drive activity, it's more impactful across all the communities within in various countries of the world. What I understand about this is that there are different communities that could help to push the fight against HIV. And as we all know, communities can be grouped into different categories. We have community of interest, we have community of change. Those are people that have prepared their mind, they want to be change agents. We also have the community of place, which speaks to where people live. You know, they are bound together by where they live or where they reside. We have community of practice, which is also linked with what people do. We also have community of circumstance. You know, people are placed together because of some situation and circumstances. For us, and for me as a person, all these category of communities need to be engaged to drive the fight against HIV. And how exactly should this be done? The government needs to channel some of the resources and activities, capacity buildings, and efforts that will ensure these various communities are empowered. There needs to be a community-led approach in which there will be a common understanding of where we are as a country. I won't stop, without mentioning the community of people living with HIV. This is where people-centered approach, or client-centered or person-centered approach is very, very important. What do I mean? There are various needs of different categories of people, but now we are streamlining. We are really streamlining to PLHIV, that is people living with HIV. There are some basic needs. There are basic, necessary things that they need, and so there is need for the government also to see some of these things and ensure that activities are tailored to meet those needs. And they also need to be part of the people that will drive the fight against HIV. There's a common saying, there is nothing for us without us, right? So that is very, very key in terms of ensuring that the community is in charge of HIV and its response. All right, so You Equals You campaign, it's actually a campaign, was launched in Nigeria on the 25th of November 2019. And basically it speaks to people being retained in treatment, right? What do I mean? PLHIV, U equals U means undetectable equals untransmittable. And this is, in a layman's language, is just talking about if someone on treatment takes his or her medication, attends hospital, clinic, and appointment. So if that person achieves very low viral load, right, the rate of transmission of HIV virus is almost zero. Yeah. So that's why U means undetectable is equal to untransmittable, right? This campaign was launched in Nigeria in 2019 by NACA, that's National Agency for the Control of AIDS in Nigeria, in collaboration with the U.S. President's Emergency Plan for HIV, that's PEPFAR. And the campaign since then had been pushed. However, at some point, because of COVID-19 issue that came on board, the emphasis on the campaign fizzled out. And knowing fully well the importance of people adhering to their medication, being retained on treatment, in 2023, February, APIN was commissioned by US CDC to work with a communication organization to create materials to wake up, conversations around U equals U. Right, so the joy of what we do in prevention and community services is that all the activities that are related or that follow our program actually hinges on the success of the prevention and community services. What do I mean? HIV intervention starts from knowing your status, and that is what this my directorate is all about. And various activities also are targeted to ensure that we follow the numbers, we follow where people are likely to be infected. We also use data to drive our activities. So for prevention and community directorate, we are able to fulfill that bit of the first 95 through deployment of activities, and strategies that are able, to make people actually desire to know their status. So we do a lot of community drive. We do a lot of community sensitization. We do targeted testing, right? One of which is where what we call index testing. Index testing is targeted towards having access to partners of index clients, people that are already living with HIV. What this does for us is like a pointer, because for an average, for a single individual who is living with HIV, there is likely to be 1 or 2 persons around, that individual. Majorly because our major mode of transmission in Nigeria and in Africa generally, all over the world, is still through sexual means. So when we see or find a person living with HIV, once that person is enrolled, we engage in conversations and discussions, client-centered, no coercion, and such. So we're able to extract some information about the immediate partners or immediate partner of such PLHIV. And on our own, we are able to reach such partner without necessarily disclosing where or how we got the detail of the partner. So that particular strategy, we call it index testing, was really magical. It sounds like you can call it a magic bullet in really finding new cases, which also led to achievement of the first 95. Along with that, there are also activities that are prevention directed, that are prevention focused in terms of pre-exposure prophylaxis, for instance. We have people who we call high-risk positive. High-risk positives. Why are they high risk? They interact with people who are already either vulnerable, who are already positive, unknowingly, who also may be at high risk of other activities. What we call them the key population. So these high risk individuals are exposed to pre-exposure prophylaxis, which are ARV drugs that are given to individuals that are at remarkable risk or higher risk of acquiring HIV. So that's one activity that's also going on to prevent new infection. We also have other campaign materials, promotional materials, targeted towards prevention. We call them IEC materials. We have prevention commodities, with like a barrier method, condoms, male condoms, and lubricants. All these are able to curb the spread of HIV, and is actually something that we also, we lead in APIN. Another big component of that is the prevention of mother-to-child transmission, which is another major intervention in Nigeria as a country to prevent vertical transmission of HIV from a mother to an unborn child. That's also very critical, because one of the programs we also do is a maternal, newborn, and child health intervention. That's MNCH, which also help to prevent new infection of HIV. So far, we've achieved great milestones in HIV intervention. And the beautiful thing is that we've moved from that period of HIV being a death sentence to people living with HIV and being able to carry out what they are doing, carry out all their daily activities, live their life as though nothing is, they're not living with any virus, right? They are also able to exert all their potentials, which is very, very key, right? So to all persons living with HIV, to Association of Young Persons living with HIV, as APIN, Association of Women living with HIV, and NEPWAN as a whole, I want to say Happy World AIDS Day. And it's time for us to build that, that synergy, working together, number one. There's also need for us to see ourselves owing various programs and intervention. Let me say that a lot of the work we are doing, it's meant to be, it's to ensure that we have good quality of life, treatment, good treatment outcome, and all that. So I would want us to take our adherence to our medications seriously. I would also want us to engage in supporting community members to ensure that they go for hospital appointments. It won't be the best approach to have one ailment or the other before visiting the clinic. We should take our health very, very seriously. And I know currently that the government of Nigeria is doing a lot of programming around person-centered activities and bringing us into the picture. So I want us to know that we are valued, and all about our well-being. It's the concern of everybody, and more so of APIN. And for my various friends out there who think it's better for me not to know my status, and what a person no go keep person. I think that's a very wrong. I would like to correct that impression, actually, because now we know that people who know their status on time are able to access treatment on time. They are able to, maintain that wellness on time. So rather than staying away from being tested, this is an opportunity. There are a lot of testing points around Nigeria. I would want to appeal to everyone. Take that bold step, to know your status. And there are fantastic healthcare providers all over the place who are trained on how to manage the counseling session, how to manage the post-test counseling, and ensure that you have access to the right information so that you can take the best decision. And of course, you might come out of the test negative. It doesn't also mean that once you're negative forever. It's also an opportunity to redo an introspective reflection that, okay, now that I know my status, how and what should I do to ensure that I remain negative, right? So both ways, it is important for one to know your status, either you're positive or negative, and access necessary treatment if positive, and take some measures or some basic precaution, if I can use that word, to remain negative. And let's deal with stigma. Stigma doesn't help anyone. And for those of my friends who are living with HIV out there, self-stigma kills faster than the virus. Please don't self-stigmatize yourself. We know that the environment might want to bring some enacted stigma, or might want to bring some labeling and all that. This is where we need to come together to fight discrimination, to fight stigma. And I know that the fight against it is a won battle already, because there are a lot of us that are really standing behind, ensuring that stigma and discrimination is finally buried in Nigeria. HIV is no more a death sentence. That is the key message. And yes, knowing your status on time is very, very important. And of course, adhering to medication and achieving viral load suppression is the goal, and that everyone should achieve, every person living with HIV should aspire to meet, because U equals you.